Okay, hello and welcome to what I hope will be an interesting three presentations on three papers, all around the issue of drivers of health, new knowledge in drivers of health. This webinar and the one that we had last week is part of the Drivers of Health project. And we can go to the next slide. If Luke is hearing me, there you go. So the Drivers of Health project is a Robert Wood Johnson Foundation funded project, and it was designed to examine what we know and what we don't know about what affects our health, all aspects of what affects our health. And it had 3 meetings last year, and those meetings started at a very broad level with an overview of what drives our health. And then we actually focused the project on the 2 areas that seem to have the best evidence, but also needing some additional work, housing and education. So that was a second meeting in Detroit. And we wrapped up our 3 meetings with a broad conversation about various systems, communities, and stakeholders that affect our health. And also part of this project was a health services research theme issue. We had, oh, by the way, before I go to the next slide, if you want more information on the project, please go to driversofhealth.org. So we can go to the next slide. And the health services research theme issue came out earlier this month. It had 14 open access articles on social determinants of health. They're open, so you can go to the site, you can find the theme issue, and you can read all those articles free of charge. The editor-in-chief on that issue was Patrick Romano, and David Narenz and I co-edited the journal. And if you want to find that issue, there's a little link there at the bottom of the screen. I'll give you a few more seconds to jot it down real quick, but it's a short URL that will take you right to the issue. So today's webinar, as I said, will have 3 15-minute presentations. I'll have a few questions, and we invite questions from you. I'm sure you're all familiar with Zoom by now, but if you go to the bottom of your screen or somewhere in the device you're using, you'll see the Q&A button. If you click on that, you can type in your questions. You can do that at any time. We will collect them, and we will get to as many as we can at the end of the 3 talks. So before we go to the first talk, I'd just like to quickly tell you who's going to be speaking. The first speaker will be Erin Morgan. She's a postdoctoral fellow in the Department of Epidemiology and Harborview Injury Prevention and Research Center at the University of Washington. For the second talk, the presenter will be Abigail Barker. She's faculty lead for data and methods at the Center for Health Economics and Policy at the Institute for Public Health at Washington University. Linda Lee, her co-author, is here. I don't believe she'll be presenting the slides, but she can help take questions. And the last presentation will be jointly presented by Aditi Vasan and John Morgan. They're both postdoctoral fellows at the National Clinician Scholars Program at the University of Pennsylvania. So I will now turn it over to Erin to get us started.
Great. It's a pleasure to be here with everyone this morning, and I'm glad that Robert Wood Johnson and everyone has been focusing on such an important topic of these social drivers of health. So today I will be talking about the earned income tax credit, and specifically state level earned income tax credits, and how some of these anti-poverty policies might influence health. Here we go. So a little bit of an overview, I'll give some background. I think most of us are very familiar and comfortable with, maybe not comfortable, but familiar with the idea that poverty is associated with poor health outcomes. So that background will really be focused more on the earned income tax credit as a policy. Then we'll dive into some of our methods and the different outcomes that we were really interested in. Dive into our results just a little bit, and then my goal is really to focus on some of the implications of this work. So a little bit of background. As I mentioned, we're mostly familiar with the idea that poverty is associated with poor health outcomes, both physical and mental illness. We know that both income and employment predict health outcomes together, but also independently. And that this has a number of different pathways, both direct and indirect, especially in a country where employment and health insurance are so intertwined. And it's also important to bear in mind that a lot of these physical and mental health concerns frequently co-occur, both because of some of these shared upstream risk factors, but also because this tends to be a positive feedback cycle where some sort of stressful event can then become physically embodied and cause some sort of physical health event. That health event or the costs associated with it then cause some amount of mental distress, and it just becomes a self-perpetuating cycle. So that's where the earned income tax credit might potentially step in. And this is a federal credit that is offered to low-earning working families. The value of the credit, much like many other tax credits or tax liability, is determined by a number of demographic characteristics. An important component of this credit is that it's refundable, and that means that it can exceed a filer's tax liability, which, especially when you're considering a low-earning family or household and someone who may have a relatively low tax liability, the idea that they are then getting a check after filing their taxes could potentially be a really important mechanism. So in addition to this being a federal credit, there are several states that also have supplemental policies, and these are credits that act against their own state level income tax. There's been a number of research articles published on the earned income tax credit, finding that it increases employment, but also a handful of studies looking at EITC and health. So because single women, single mothers are the people who are the primary recipients of the credit and the largest beneficiaries of the credit, maternal and child health has been one of the major areas of focus. And they have observed benefits such as a reduction in pregnancy complications, a reduction in adverse birth outcomes, and better child development. We've also seen evidence that this credit can reduce child maltreatment, and this has been associated more with the refundable EITC. The presence of a non-refundable EITC doesn't seem to carry the same benefit. And finally, there's been some research looking at the impact of EITC and suicide, and these studies have had mixed findings, but 2 of the 3 have shown a reduction in suicide deaths. And there's been some variation in the study population there, but again, largely focusing on women and women with a lower educational attainment. So for our paper that was just published, we were interested in those state level tax credits. So we only considered the refundable credits because, as I mentioned, the prior literature suggests that non-refundable credits have little to no benefit. We measured our exposure as a 10 percentage point relative to the federal credit. And this is because a lot of states, when they pass a earned income tax credit, it's legislated as a percentage of the federal credit. And all of this data is publicly available from TaxSim, which is produced by the National Bureau of Economic Research. And I'm fortunate enough that one of my colleagues, Nicole Kopsky, was willing to supplement the information that they had provided and make sure that we had measurements that were 100% accurate. So thank you to her for going through all of those state tax forms to find those data. Our outcomes of interest all came from BRFIS, which is the Behavioral Risk Factor Surveillance System. This is a nationwide telephone survey conducted by CDC and state health departments. It's representative at the state level and interviews folks over the age of 8, non-institutionalized adults over the age of 18. about different health behaviors and health outcomes. So our areas of interest were suboptimal health, and this was measured on a Likert scale, frequent mental distress, and frequent poor physical health. And the frequent poor health outcomes, people were asked, out of the past 30 days, how many days would you say your mental health or your physical health was not good? And people who reported 14 or more days of poor health were considered to have frequent poor health, either mental distress or poor physical health. And those are guidelines set by CDC. So some of the covariates that we included, we were concerned that potentially some of the state level economic conditions could influence our observed relationships. So we did adjust for minimum wage, the state GDP, and whether or not a state had enacted Medicaid expansion. We were interested in some individual level variables, but really only looked at those in terms of effect modification. So because we were interested in folks who had a lower earning potential and were most likely to benefit from this policy, we were restricted to people who reported no more than a high school education. And then we did a sub-analysis that I'll show shortly that focused on the responses only from tax season, that late winter, early spring period. And there's data that suggests that people who know they're receiving a refund, I know I did this when I was a student getting the education tax credits, will file earlier because they know that they're getting a check. So why not get that cash transfer earlier rather than later? And then of course, for a difference in differences model, we included fixed effects for state and year. Our overall findings. So first, taking a look at the variation in EITC over the study period. There were several states that enacted a new earned income tax credit during our study period. There were several states that did not have an earned income tax credit. And for some states like Washington, where we don't have a state income tax, that makes sense that there's no income tax to provide a credit against. And then there were a couple of states that were early adopters of the state earned income tax credit. And so they did have an EITC for the entire duration of the study. So when we looked at the year-long results or the reports from interviews coming in over the course of an entire year, we found overall that among individuals with no more than a high school education, we saw a reduction of 150 per 100,000 reports of frequent poor physical health. And this was for a 10 percentage point increase in the generosity of a state EITC. And again, that's being measured relative to the federal credit. When we focus more on that early spring period, we see that the most significant benefit, both statistically and in terms of practical significance, is in frequent mental distress. And that was a reduction of nearly 330 reports per 100,000 adults. So potentially some very substantial impacts for a 10 percentage point change in a state level EITC. Transitioning here to some of the implications of this work. Overall, we're finding that the state EITCs were beneficial to frequent poor physical health, and we see that during the year-long analyses, but not during the immediate effect, but no immediate effect during the spring period. And I think this is suggestive that there's potentially a number of mechanisms at play. We can think about the idea that because EITC promotes employment, people feel that they have a more stable income. It's potentially that people are getting that cash transfer early on and are able to pay down a deductible for whatever health insurance they have and then can continue to seek health care throughout the year. So several potential mechanisms there. When we look at EITC and the frequent poor mental health in that shorter window during tax season, I think our results that it's more substantial during that tax season is suggestive that the benefits are occurring via the cash transfer. So they're receiving that check rather than just the increase in employment is potentially one of the strong drivers of the benefit. And what this means in terms of options for policy advocacy and future research, I think the exact mechanisms could be better understood. So we've mentioned the cash transfer. Our data is suggestive that the cash transfer is what's playing a strong role for the mental health benefits, but it's less clear what's playing a role for the physical health benefits. And if we could better understand what parts of employment are improving health, we could potentially provide interventions that are directly aimed at improving those things, be it more stable income, be it more stable insurance coverage, or some of the social connections that we find through our employment. This data, I think, also suggests that there's an off-target benefit of EITC. And by that, I mean, we, I think, talk frequently about unintended consequences of different policies, but not necessarily consider the unintended benefits. And so this poverty, which is very successful as an anti-poverty policy, also seems to have benefits as a health promotion policy. And then finally, I think this is important in considering that we as health science researchers and practitioners might have a role to play in advocacy that isn't specifically health related. I think I also work in gun violence and suicide prevention. You may have heard, I think it was last year, there was a lot of pushback that we're supposed to stay in our lane, but there is definitely room, I think, for us to advocate for policies that do have health impacts, even if that's not necessarily what they were designed to do.
Thank you. That was a very interesting and informative presentation. I'm going to ask you one question now, and I'm sure there'll be others after all the talks. So one thing you mentioned is that EITC promotes employment. And we all know employment affects health insurance coverage, and both of those affect health. So, but I noticed in your models, you elected not to include unemployment rates or percent uninsured. And I'm wondering if you could explain a little bit about your reasoning with those choices.
Absolutely. So we spent a lot of time in our internal meetings thinking about this and trying to decide how we wanted to form these models. And we were somewhat concerned that this would have kind of an impact in terms of endogeneity, that the percentage of people employed and the health insurance less so, but the percentage of people employed would influence whether or not a state enacted an EITC. And similarly, a person's level of employment would influence whether or not they qualified for the EITC. So because we didn't want to have things that were actually downstream effects of the earned income tax credit, we wanted to avoid adjusting for those and taking that into consideration.
Okay, thank you. So why don't we move now to next presentation? And Abby, I think you're going to be doing that, right?
Yes. So I'm going to pull up my slides. And while I'm doing that, I just want to say thank you very much for the opportunity to present, and thank you to those who are participating in this webinar. There we go. Hope you can see the slideshow. So today I'm going to be talking briefly about a paper that I did jointly with Linda Lee, who is on the webinar as well, investigating the cumulative impact of health insurance on health status. And so just a real quick outline of what I'm going to go over in the next 12 minutes, a quick overview of the motivation for the question, a quick slide of data and methods. I'm going to spend most of the time on key findings and then wrap up with a little bit of relevance to health policy as I see it. So just as background, I'll start by saying probably most of the people on the webinar are aware that evidence is accumulating that health insurance is associated with healthcare access and improved health outcomes. In particular, there are studies that have pointed to causal linkages. There are studies using county level observations and population level metrics. There are also studies that look at specific subpopulations and that look at longitudinal data over a period of maybe 1 to 2 years, in particular as studies start to assess the impact of Medicaid expansion starting in 2014. But no study that we found really looks at this at the population level. And so that's what we were interested in doing. And the other motivation, I think, from a practical standpoint, from a policy standpoint, is really to connect this conceptually to cost and utilization. And people who report excellent, very good, or good health status have much lower utilization and costs than people who report fair or poor health. If you look at the 2017 Medical Expenditure Panel Survey, I've summarized the utilization averages there. And I think that in itself points to a certain motivation to try to figure out how to predict and understand what causes people to fall into fair or poor health, as the utilization is so much higher, indicative both of their own sort of experience of bad health and also the strain to the scarce resources of the healthcare system. So quickly, I'll just go over how we set this up. We use the panel study of income dynamics over a period of time. That's a biannual survey, so those are odd years. So those are actually 5 years of data. We restricted it to heads and spouses because those are the respondents for whom the health insurance variable was available only beginning in 2011. Previously, the PSID really looked at insurance as a household level or family level concept. And so that's kind of why we had the opportunity to look at this and no one had already done it. We used 2009 as a reference year. So all of the demographic variables and sort of the health status prior to the period that we're looking at, those are all indexed to 2009. We constructed a few percent of time variables. So this was the idea of capturing this idea of exposure to certain things over the period of the 4 measured years, 2011, 2013, 15, and 17. And so we have percent of time covered by health insurance, percent of time below the federal poverty level, and percent of time that the individual reported work limitations. So then we ran unconditional and conditional logit models. I'll explain a little bit more about how that was set up when I show you the findings. We controlled for some of the most likely covariates that would tend to influence this relationship between insurance and health, such as educational status and age and race and ethnic group. So the variables of interest, the outcome variables we looked at, were being in fair or poor health by 2017, death by 2017, and the presence of work limitations by 2017. So before I get into the multivariate findings, I want to just show you the bivariate relationship between self-reported health status and the degree of insurance coverage. So I think this is a pretty telling chart. If you look at the percent of time with insurance coverage indicated in these groups with the different colors for the degree of insurance, the people who are fully covered in the yellow are much more likely to have been in this excellent or very good health status group. So 82% almost of those who reported excellent or very good health in 2017 had been fully insured for the prior 4 measurement periods. And you can see that relationship is exactly in the direction that you would expect. And in particular, that people in fair or poor health are much more likely to experience some significant gaps in insurance coverage over that period of time. So then moving along to some of our our analytic findings with the regression models. So this table is unconditional odds of all outcomes. This is fair or poor health in 2017. These other outcomes here I'm not going to talk about, but please feel free to read the article. And so this is really showing us that the percent of time insured over the measurement period is associated with a reduction in the odds of being in fair or poor health in 2017. And it looks like a small number, but remember that this is each percentage point of time. So if you think about this as one measurement difference, going from 4 years of measured coverage to 3, that's actually 25 percentage points. And so that result was significant. However, and by the way, let me just parenthetically point out that a lot of our other covariates were significant as well. Age was significant, race was significant, the educational level, all as expected. Having college or above college education dramatically reduced the odds of being in fair or poor health in 2017. But the real key point to make here, in addition to the one I've highlighted, is that we do have fair or poor health in the model here, fair or poor health in 2009, and the result is extremely significant, right? So if you were already in fair or poor health, that's going to be highly predictive of being in fair or poor health in 2017. So we wanted to move on and look at a conditional model that basically starts out with people who were not in fair or poor health as of 2009. And when we do that, when we restrict the sample to that subset, that does increase the magnitude of the finding. In other words, the odds of falling into fair or poor health are even lower the more you've been insured. And so, this 0.4% difference is actually about a 10 percentage point difference when you multiply it by 25 percentage points of time corresponding to one measured year. So that's a pretty strong finding, actually, I think. However, I do want to point out that this is experienced really unevenly across racial groups. So we found that the result was almost entirely driven by the experience of whites in the sample, and not at all by Blacks, and not significantly by the other racial group. So that in itself is a source of something that we can discuss. The other thing I would just add is that the percent of time that one was above the poverty line does have the expected effect. If you are not in poverty, it tends to be better for your health. And that was actually true consistently across all the groups. So in the full column here of all racial groups, and then across the subgroups as well. So I think that just to kind of summarize and give a few thoughts about the policy relevance, this is certainly not ironclad evidence of a causal relationship, which is a very elusive thing, I think, to find. I do think our findings indicate a dose-response relationship between health insurance coverage and self-reported health. We're controlling for many of the common covariates that would be likely to cause statistical bias. And so I think that this does add to that evidence base. And it has particular implications for states that have not yet expanded their Medicaid programs. It suggests that people who are currently uninsured could perhaps better maintain their health over time, and incidentally incur lower costs if they were granted access to Medicaid coverage. So I think, to me, that's one of the key findings, and it was something that I was kind of interested in seeing if I could show. And then the different findings by race suggest that health insurance coverage may not be experienced in the same way by minorities, and I threw out some possible reasons: quality of coverage, discrimination in healthcare access. And it would be really nice to unpack that and really understand why that doesn't seem to create the same benefit for minorities, at least in our version of of addressing this research question. And so policy should obviously be working to address that. So with that, I will pause and see what question you have for me.
Okay, thank you. And I'll just remind everyone listening that they can submit questions with the Q&A button at the end, at the bottom of your screen or somewhere in your app. So please submit questions at any time. Abby, I have a few questions for you. I'll ask one now and maybe save the other for later. So you're in Missouri, and this summer voters there elected to expand Medicaid, and you mentioned the general direction you expect things to go from your work through insurance expansion like that. But maybe you could tell us, or can you tell us something more specific about what Medicaid expansion will do in Missouri in particular, or what it means to that state?
Well, I think that in Missouri over the past 20 to 30 years, we've really seen ourselves drop in the population health-based rankings. We've gone from right in the middle of the pack, right around 25th on a lot of the different rankings, to 40th, 42nd, 43rd. We've really been plummeting. And I see that as happening because there's not been enough sort of intervention, if you will, at the population level when it comes to thinking about health. The framework has been, we wait until you're really, 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 really sick and quite disabled, and then we help you. So our Medicaid program is actually, I think it's very helpful to people who are qualified as disabled. But if you're not qualified as disabled, we have one of the lowest eligibility thresholds for custodial parents in the country. It's right under 20% FPL. And obviously for non-custodial adults, we have nothing. And so, I really see this kind of analysis as helping to kind of frame what we might expect. Again, over time, this is a study over a cumulative 8-year, 10-year period. It's not quick and easy, but I think this will help Missouri over the next 10 years, maybe, regain its middle of the pack footing and maybe be able to go forward from there.
Okay, thank you. As I said, I'll hope to return to another question at the end.
Thank you.
But why don't we move now to our next speaker? And is that John? Are you coming on next? Yeah.
John and Aditi, and I'll let Aditi take it away first.
Okay, thank you.
All right. So Abby, if you can just stop sharing your screen, I'll pull up our presentation. So thank you so much for the opportunity to share our work. John and I are really excited to be here today to talk to you guys about our project, looking at the effects of a standardized community health worker intervention on hospitalizations through a pooled analysis of 3 randomized clinical trials. So we know that hospital-based care in the United States is both costly and inefficient. The US spends $1.1 trillion on hospitalizations each year. And a lot of these hospital stays are driven by factors outside of the health system, the social drivers or determinants of health. Recognizing this, CMS and others are increasingly incentivizing health systems to move upstream and address the social drivers of health. And so the question that motivated our study was, can addressing some of these social drivers lead to a reduction in hospitalizations? And to look at this question, we studied an intervention called IMPACT. IMPACT stands for Individualized Management for Patient-Centered Targets, and it's a community health worker intervention that was created through participatory action research, including interviews with hundreds of patients who had recently been discharged from the hospital about really the support they thought they needed to stay healthy in the community. IMPACT is run out of the Penn Center for Community Health Workers, and the intervention itself has 3 steps. The first is goal setting, in which a community health worker meets with a patient and talk to them about their health-related goals and the things they think they need to do to stay healthy. The second is tailored support, and I think this is an area where IMPACT is really unique. So IMPACT community health workers certainly provide support in the form of making sure patients make it to their appointment or take their prescription medications the way a traditional patient navigator would. But they really go beyond that to provide support that's tailored to patients' individualized goals. So for example, for a depressed single mother who felt she never had time for self-care, the community health worker provided an appointment at a local beauty salon so she could have some time for herself. These kinds of interventions are really focused not explicitly on the health system, but on helping patients meet their identified goals. And then lastly, and importantly, the third phase of the impact intervention involves connection to long-term supports. And this is because in designing the intervention, we recognize that these patients who have complex chronic conditions are not likely to have their drivers of health resolved by a 6-month intervention. So at the end of the intervention, the community health workers are responsible for connecting patients with support either in their family or their community, or through actually a support group that is run at some of the academic primary care clinics at Penn, specifically by community health workers for people who have completed the impact intervention. Impact, as I said, really centers around community health workers who are trained and trusted lay people. Impact CHWs are hired based on personality traits, including empathy and a natural interest in active listening and helping others. Each community health worker works with a panel of 55 patients, and then every group of 6 community health workers is supervised by a community health worker manager who is typically social work trained and helps to ensure the fidelity of the intervention. So as I mentioned, this study was a pooled analysis of 3 randomized controlled trials. Trial 1 looked at 2 weeks of impact among hospitalized patients. Trial 2 looked at 6 months of impact at 2 academic primary care clinics. And Trial 3 looked at 6 months of impact at 3 different sites, an academic, a VA, and an AccuHC clinic. These 3 studies showed that impact improved patients' access to preventive care, their mental health, and their perceived quality of care, but they weren't individually powered to look specifically at hospitalizations, which is what motivated our pooled analysis. Our primary outcome of interest was all-cause hospitalization as measured by total hospital days per patient, and average length of stay. As secondary outcomes, we looked at 30-day readmissions, and then we also looked at hospitalizations outside a patient's primary health system, something we termed fragmentation of acute care. We chose this as an outcome because there's evidence to suggest that hospitalizations across multiple health systems are less efficient and more costly because patients often end up getting tests repeated unnecessarily. And then as exploratory outcomes, we looked at admission acuity as measured by DRG, because we wanted to see whether impact differentially impacted high versus low acuity interventions. And then we also looked at trends in hospitalization over time. So what would happen when the intervention ended? Did impact patients go back to having hospitalizations at a higher rate, or did the effects of the intervention persist? I won't spend too much time on our Consort diagram, except to tell you that of the 2,500 patients across all 3 trials who were determined to be eligible for impact, about 40% declined the intervention. So we'll come back to this in our limitations. And then the remainder of patients were randomized to either acute care or the community health worker intervention. And data for our primary outcome, which was hospitalization, was available for all but 4 control patients and all but 2 intervention patients. Across all trials, all patients who were enrolled had 2 or more chronic conditions, and most were Black, female, and unemployed. There were some notable differences in characteristics, and which I'll highlight here. Most notably that trial 1, which recruited patients in the hospital, had a greater proportion of patients who were uninsured, had a household income under $15,000, and had 1 or more hospitalizations in the previous 12 months. Notably in trial 2 and 3, only about a third of the patients were hospitalized in the previous 12 months. So although these patients were certainly at high risk of hospitalization, they weren't necessarily super utilizers. And I'll turn it over to John to talk through the rest of our results.
Thanks very much, Aditi. To cut right to the chase, results of our findings were that the incidence rate of hospitalizations per patient were 66% in the intervention arm that they were in the control arm, correlating with a hospital day per patient of 1.26 in the intervention arm as opposed to 1.9 in the control arm. And without getting into the nitty-gritty, this was assessed over either 30 days, 12 months, or 9 months, depending on the control trial. However, patients in the intervention and control arm were assessed at equivalent time points in each of those 3 studies. Looking at the This was really driven by both a reduction in the mean number of hospitalizations, as you can see, an incidence rate ratio of 0.8 in the intervention relative to control, as well as a significant reduction in the mean length of stay. Next. As we try to characterize more broadly these findings, we made several additional interesting discoveries. The first was that there was also a significant reduction in the percentage of patients who had multiple hospitalizations, as well as a significant reduction in the percentage of patients who had hospitalizations outside of their primary care system. Again, as Aditi mentioned, this, we interpreted as a reduction in the fragmentation of care, with both implications as to why we had potentially witnessed a reduction in hospital days, as well as potential benefits in terms of the quality of the care that was delivered. It's worth mentioning that there was not a significant reduction in the percentage of patients with readmissions within 30 days, potentially most notable given the high attention and prevalence of this metric as an assessment of readmission services throughout healthcare. And for us, while it was not a major focus of the discussion, it does raise questions, given the significant reduction once we looked out to 9 to 12 months, it raised flags and raised questions as to the appropriateness and utility of 30-day readmission as a standard assessment tool. As Aditi mentioned, we also looked at the mean diagnosis related group of the individuals who were hospitalized in each group. And for those less familiar with DRG, this is essentially one way of assessing the acuity of a hospitalization. The fact that these were essentially equivalent, or at least are not significantly different, were meaningful for us in several ways. But of note, one potential thought or assumption was that a reduction in hospitalizations via community health workers may or may not have resulted from a change in actual health. And it may or may not have been the result of channeling or diverting patients to or away from hospitalizations. The fact that there was not a significantly higher relative acuity in the intervention admissions, while not definitive, potentially suggests that this reduction in hospitalizations was not just accomplished by reducing instances where hospitalizations occurred in low acuity individuals. And as Aditi mentioned, we also were interested in exploring whether this reduction in hospitalizations persisted beyond the end of the intervention period. One thought and one concern was that if in fact impact was reducing hospitalizations purely by keeping patients at arm's length and away from the hospital for reasons unrelated to improved health, we might actually see a rebound in hospitalizations after the end of the intervention period. But as you can see here, going at least 3 months out post completion of the intervention, we see what appears to be relative maintenance of that benefit persisting at least 90 days after completion of the intervention. So to summarize briefly our key findings, the first is that a structured and standardized community health worker intervention did reduce hospitalizations as measured by total hospital days, and that this appeared to be both by virtue of fewer hospitalizations and shorter length of stays. Secondly, and additionally, I'll add that fewer patients in the community health worker arm had hospitalizations outside their primary health system, and that these reductions in hospital use did persist for at least 3 months beyond the end of the intervention. So to acknowledge some limitations, firstly, 40% of our eligible patients declined participation impact. Additionally, we know that the population that we assessed was limited to acute care or patients who were admitted for acute care episodes in Pennsylvania. And as you'll see, the vast majority of these were African-American individuals and constitute a population that may not be perfectly replicable in all instances and among all populations. Additionally, the duration of follow-up was somewhat limited, and it would have been preferable had we been able to monitor patients and outcomes for an even longer period of time to assess trends over time. Next. Oh, one more. In terms of policy implications, thanks, Aditi. First of all, this provides additional important evidence that health system-based social interventions that are tailored to or interested in reducing hospitalizations should really be constructed around tailored longitudinal and relationship-based support. And this speaks to the fact that multiple previous studies and many looking at the efficacy of socially oriented interventions to reduce hospitalization have often failed to show a statistically significant reduction in hospital utilization. Secondly, and additionally, we know that community health worker interventions seem to improve patients' perceived connection with the health system, which we extrapolate based on the fact that there was there were reductions in fragmentation of care, and that this potentially not only has ramifications on utilization, but on the quality of that care that's delivered. And lastly, by reducing hospitalizations, community health workers can, and it's been shown in other studies of this impact model, produce a positive return on investment for health systems and payers, depending on how those those costs are shared. Finally, to add an additional COVID lens to these findings, it's worth mentioning that beyond the benefits demonstrated in our study, it's very likely that community health workers can help both preserve acute care capacity by virtue of reductions in the need for acute care. Secondly, we know that they provide an opportunity to not only serve a population that is often very vulnerable, but create needed jobs that have significant evidence based at a time when jobs and economic recovery are most pressing. Additionally, we realize that community health workers have been currently and could in the future be used to supplement contact tracing activities. And lastly, we know that trust and relationships with health are potentially more vital now than they have been in the past by virtue of vaccines, and threats to that relationship are something that community health workers could help address. To mention future directions very briefly, it's worth mentioning that in terms of future research, there's still much to be understood about heterogeneity in terms of who community health worker interventions are effective for and how populations that can benefit most might be identified. Additionally, it's worth mentioning that building and deploying lower touch interventions beyond our traditional community health worker model are both worth investigating, and there's understandably a significant need for a wide range of socially oriented services. And lastly, advocacy for community health, for policy that will promote and permit adoption of community health workers remains highly important. And with that, we will thank our wonderful study team and turn it over to Austin for any questions.
Yes, thank you. So we will move in a moment to general questions from the audience. I already have some prepared, but before we do, I'll ask John Aditi one question about your study. I'm wondering what you think made the impact intervention particularly successful, especially around hospitalizations, compared to any other social intervention you wish to compare it to. And one thing in particular, maybe in your answer you could shed light on is, can you say more about what the community health workers may have done, in their engagement with patients that led to those outcomes?
Sure, I can take that. So again, I think I'll draw your attention back to the structure of the impact intervention and say that it was really unique in that community health workers weren't tasked explicitly with keeping patients outside of the hospital. Really, their focus was on meeting what patients felt like their goals were in order to stay healthy. And I think that's something that's relatively unique among health system-based social interventions. It wasn't tailored to a specific condition or to a specific health outcome. It was really tailored towards getting patients what they felt they needed. Secondly, I think the longitudinal support component of this intervention is likely part of what made it uniquely effective. Again, we know that these patients have social conditions that have been affecting their health for a long time, and that in 6 months, you're not necessarily going to be able to resolve these issues. And so I think really providing people with connections, with supports in their families, in their communities, or even longitudinal support through impact probably made a big difference. And then lastly, I'll note that, again, as John mentioned, across all 3 trials, our patients were homogenous in some ways, and that they were mostly Black, female, unemployed, and in trials 2 and 3, they weren't necessarily the highest utilizers. And so I think that it remains to be seen whether our findings are generalizable to other populations as well.
Thank you. So now why don't I invite all the speakers back on camera. and we can, we have a few more questions for you, and some more questions may come in from the audience. Also, I invite you to ask questions of each other if anyone has something they'd like to ask. You can jump in right now and before I ask more. Okay, not at the moment, but if you think of one, please jump in, between the next few questions. So why don't I go back to Aaron? Your analysis found, a particularly larger impact right around when the refundable credits, are made available to individuals right around tax season. And I was wondering, I don't know a lot about, the different variations in state EITC programs, but do any states implement kind of advanceable credits where they make them available, over the course of the year, and then of course would have to reconcile tax season if they overpaid or underpaid? And if they have, whether you could speculate, or maybe you observed any differences for those states, and if they haven't, maybe you could speculate if that would have an impact, because it would spread the benefit across the whole year, so maybe it would be less perceptible in some way. So feel free to speculate.
That's a really good question. I am by no means a health economist, so I'm actually not sure whether some of these states have advanceable refunds, but that's a great question that I will definitely bring up to discuss with some of my colleagues who are more in the public policy realm. As to whether or not we would see the same benefits as if it were spread out over a longer period of time rather than in a single lump sum, I think there have been mixed findings from other social safety net programs that do have that that cash transfer in smaller amounts over a longer period of time. I don't know that the mental health benefit would be as observable. I think the fact that there's this one lump sum and all of a sudden it can provide a large amount of relief. And if people are comparing their mental health to kind of their own personal baseline, that relief would be more noticeable if they're receiving a large lump sum. But that's a really good question that I think we should dig into a little further.
Okay, thank you. Again, feel free to jump in if you all have any questions. Meanwhile, I'll turn to Abby and Linda. Your study found that the insurance coverage was less protective for people who are Black than people who are white. And I'm wondering if you could speculate what might be driving that difference. I know your study didn't dig into fully explain, but I'm asking you to speculate, so go ahead.
So I'll start, and then I want Linda to also give a speculation or two, because I know she looked at some of the other literatures that kind of related to this point. I think that there seem to be two main hypotheses in my mind, one of which is that if African-American respondents of the PSID are more likely to be concentrated in the Medicaid program. And of course, if you've seen one Medicaid program, you've seen more Medicaid programs. So it'd be really hard to unpack that. But if there happens to be a concentration of people who are in sort of subpar kind of Medicaid programs, I guess that, or maybe they have not that great employer-sponsored coverage because they tend to be maybe in a lower kind of echelon of job. Maybe that could, they have health insurance according to the data, but it's not maybe as high quality. And then I think the other element is, I think we know that there is discrimination in practice patterns and how people experience the healthcare system. And so you may have insurance and you may not feel comfortable using it, or you may get blown off when you try to use it, or, you just may have a different experience as an individual. But if Linda wants to add something, that would be great.
Yeah, thanks, Abby. I definitely agree with what you said. When I was looking at the literature to try to understand this result a little bit better, I found that in the Medicaid expansion, work, they found that expansion was more effective in improving access and health outcomes among white low-income childless adults, and it had few favorable impacts on access and health outcomes for Blacks and Hispanics. And I did want to also mention that in the PSID, we didn't have like the type of insurance, so we didn't know if it was private or if it was Medicaid and public.
All right, thank you. Aditi and John, I have a really hard question for you. And if it's too hard, you know, just wave me off and I'll ask you an easier one. So the really hard one is whether you can put your hospital utilization reduction finding in the context of other interventions, other therapies that reduce hospitalizations for patients, for example, patients with chronic conditions, like maybe looking at clinical trials data from like heart failure medications or something that reduce hospitalizations. Like how, if the intervention you studied were a medication, like, is it more effective than a lot of medications, less effective, about effective? What would you say to that?
Oh boy, I'm going to take a stab and then I'll let Aditi clean up my mess. And as long as we're all on the same page, this is purely speculative.
Of course, of course. No, this is not being recorded.
Yeah, good. I mean, I would venture to say that, things like the heart failure population that as an internist I'm relatively familiar with, I'll be honest, I think we've seen at least, 2 or 3 or 4 negative, randomized controlled trials in the New England Journal in the last, 16 months alone, looking at, whether we can augment our existing, evidence-based best practices, even in reducing heart failure readmissions, let alone mortality. And I think we've seen that it's difficult. Now, this is not to say that impact is more effective or valuable than an ACE or a beta blocker, in part because we've already set a fairly high bar in some of these clinical scenarios. And so, I think, if there's a way of kind of backing our quote unquote horse, we're obviously very biased, but I think that, to kind of the question you posed to Abby, I think there's, this question of whether there is a huge almost arena of unmet social needs that, impact is, and not just impact, but, socially oriented interventions are, we know that there's a lot of room and the needle could, at least in theory, move quite dramatically. And so without kind of comparing apples to apples, I'd say that I think impact is, rather significantly effective in this regard. I think it speaks to how much of a need there is for interventions like this. And I'll let Aditi, add even more insight to that.
Yeah, I think the only thing I would add is that impact isn't condition specific, right? And a lot of the interventions that we study are going to improve outcomes specifically for heart failure or for COPD. And I think one thing that was unique about our intervention is that it worked for patients across a wide range of chronic conditions, including patients with multiple chronic conditions. And so I think when you think about what actually brings people into the hospital repeatedly, it's not always one poorly controlled disease. Sometimes it's a sequence of circumstances or a set of things that sort of sets off a chain reaction that makes someone have to come back in. And so I think it's a unique opportunity to intervene on more than one thing with a single intervention.
Right. So we should put community health workers in the water, basically. It's good. It's good for everybody.
More or less.
I'm gonna wrap it up there, but I do want to end by commending all of you on your work and getting the papers completed and in. I know it was a long process because I observed it and I helped manage the reviewing of your papers. It started well over a year ago, as you all know. And I'm in this job too, so I try to publish as well. So I know it's a lot of work, and you all also should be commended for great presentations that just blew me away in terms of how much you got done in almost exactly 12 minutes for all of you. So that's remarkable to be able to do all that. So thank you. And again, thanks to RWJ for sponsorship and Health Services Research for the opportunity. We're going to wrap it up here. I'll just remind everyone you can go to the Drivers of Health website for a lot more information about the project. And we will be posting the recording of this webinar as well as last week's on that website. So check it out there, and have a great day, everyone.
Thank you.
Thanks, Austin.
Thank you.
Thank you.